So, Dr. Rajvi, when should we
We are
start
starting.
off?
We are starting. So I'll just start. So good evening, everybody. This is Dr. Rajvi here from ACE, and I invite you all to our third journal club. We're going to discuss a very interesting paper which talks about does sperm selection technique affect ploidy status? And later this month, we will be celebrating the 45th birthday of Louis Brown. And I must admit that in these 45 years, IVF has undergone a tremendous change. But as far as sperm selection techniques go, there hasn't been much. We still use the swim up, which was something that Edwards worked on in the 1960s. We have the double density gradient, which came in the 1980s. And then there are so many new techniques which have come and gone. And therefore, we found this particular paper coming from New York, from Palermo's group, about how a sperm selection technique can actually modify the ploidy status. So we have with us Dr. Krishna Mantravadi. Dr. Krishna is the scientific director of OSS. He is an MBBS and a clinical embryologist. And he was specifically selected to discuss this because he himself has done a lot of work on sperm selection techniques. So welcome, Dr. Krishna. Then we have our moderators. We have Dr. Prabhakar Singh. Dr. Prabhakar Singh is from Gujarat. He is MD in chest medicine and for the last 15 years has been working in clinical embryology. He also has a very unique perspective on embryology considering his background. And then we have Dr. Harita Gevaria, who has actually done her PhD from the University College of London. And primarily she's worked on pre-implantation genetic testing. So we thought we have here with us two clinical embryologists, and we have somebody who is a pure geneticist who has spent her entire doctorate life working on PGT, so who will have a very critical view on the paper. So without much ado, I hand over to Dr. Krishna. Welcome, Dr. Krishna, and thank you very much for joining us. Over to you.
Thank you, Dr. Rajvi, for that kind introduction, and good evening, everyone. So good to see you all here this evening in this journal club.
Critical view on the paper. So without much ado, I hand over to Dr. Krishna. Welcome, Dr. Krishna, and thank you very much for joining us. Over to you.
Okay, Dr. Rajvi, for that kind introduction, and good evening, everyone. So good to see you all here this evening in this journal club. Okay. I'm hoping the technical hitch is taken care of and I can get started. All right, so this paper is from Palermo's group at Weill Cornell University, New York. So the title is Can a Sperm Selection Technique Improve Embryo Ploidy? Published in Andrology, December 2022. Got a high impact factor of 4.5. So let's just look at the background first. So we all know of the various sperm functional tests that scientists have worked. I think sperm DNA fragmentation seems to be having some kind of clinical correlation, and it's kind of helping us in management of patients to an extent. So we all know with the literature that is published in the past that if there's sperm DNA fragmentation beyond a certain percentage, it can bring about suboptimal embryo development, recurrent implantation failures, recurrent miscarriages. And just with the mere fact that we all are doing ICSIs for every patient, where we are forcing fertilization, embryo development, and pregnancy, if a fragmented sperm is used and still makes it to pregnancy and live birth, there can be a potential risk of epigenetic changes is what is proposed. So that's the thing that we all know. I think there are newer dimensions that scientists are looking at, and that is what this paper is all about, and let's discuss it in detail. So, now there are a couple of groups which have started looking at a correlation of sperm DNA fragmentation. Would it increase the embryo aneuploidy? We know there are several other factors, from a female factor, male factor, which can predispose to a higher instance of embryo aneuploidy. But the newer thing is a single stranded or double stranded DNA fragmentation, increasing the embryo aneuploidy. That's an overview of the various sperm selection methods which have been tested, which can try and minimize or help us recover sperms with good DNA integrity. The basic method, which all of you use, double density method, can also to an extent filter the sperms with good DNA integrity. Then magnetic activated cell sorting, the PIXI, IMSI, and the recent addition, microfluidics. I think there's been a lot of publications, focus of a lot of groups working on microfluidics. So I'll not get into greater details of microfluidics. We all know the principle behind it. But the two things that microfluidics has an advantage or thought to really help. One is it kind of helps filter motile cells in a better proportion. And even in samples where the motility is very low, it can still be implemented. And second, of course, it helps us separate sperms with good DNA integrity. And that is where probably this group of people at Weill Cornell wanted to see if microfluidics, sperm sorting by microfluidics technique, would it help us improve the embryo ploidy status. So this was a retrospective study done over a period of 4 years, and there were only 57 patients that they considered after the exclusion criteria. The age group here, maternal age, was in between 29 and 39 years, and men of ages between 31 to 56 years. Specifically, when it came to the male partners, I think the exclusion criteria was severe oligoasthenia teratocases, people where there was history of smoking, or there was varicocele that was clinically elicitable, or men with high BMI were all excluded. Female factor, if there was a known factor for an implantation failure like a uterine factor, then I think they were excluded from the study. Coming to the materials methods, I think what they did was the group of people who underwent the first IVF cycle, where a double density sperm processing method was used. We do not know what was the indication, but these couples underwent ICSI and PGTA. They looked at the ploidy status, and the euploid embryos were transferred, and reproductive outcomes were looked at. But this first cycle, these 57 women who got recruited had an abnormally high aneuploidy status. And it was unexplained, is what the author puts across. There wasn't a valid reason that they could investigate in these 57 women, and they wanted to see if it was the sperm that was responsible. So they picked up this 57 women, they got a sperm DNA fragmentation, and they saw that it was raised. Then in the subsequent second cycle, instead of double density, they used microfluidic sperm sorting. And then they did the ICSI, PGTA again, and they looked at the ploidy status, and the euploid embryo was transferred. So the major difference between the first and second cycle in this study population was the way they did the sperm prep. And additionally, what the author also considered doing was, in the second cycle, they also wanted to look at the DNA fragmentation post-intervention. So they took the semen sample, they made 2 aliquots, one aliquot, and they did a DNA fragmentation of the raw sample. Then one aliquot went for double density gradient, and then they did a sperm DNA fragmentation testing. And another aliquot went to microfluidics, where the sample was again tested for DFI. So they wanted to see which sperm preparation method would give a better separation of sperms with good DNA integrity. So there are 2 things that the author looked at apart from the ploidy. So these were the outcomes measured. So they looked at the sperm DNA fragmentation on raw sample and post process. They looked at the fertilization rates, embryo euploidy rates, and in pregnancy outcomes, implantation rate, clinical pregnancy, and live birth rates. So coming to the results, I think this table here is showing the overview of the semen parameters. So of everything, what is significant is those two red boxes that I've highlighted. So if you look at the total motility, you look at the recovery with double density method, on an average, they had around 70% of total motility that was progressive. But if you really look at microfluidics, I think almost 97% total motility was observed after intervening with a microfluidic chip. So they feel that microfluidics was giving a higher concentration of total motile sperm concentration. And second, they also looked at SEF, was the sperm chromatin fragmentation, is what the author defined or abbreviated in this paper. So that's sperm DNA fragmentation. So they looked at, when they did a double density gradient, on an average, the raw sample had a 26% fragmentation, which post double density had come down to 18%, which I think still is a normal value. But if you look at microfluidics, from 26%, it almost went down to 1.9%, which was statistically significant, and a remarkable reduction in sperm DNA fragmentation. So looked like microfluidics seems to be a method of sperm preparation and selection to optimize sperms with good DNA integrity. So coming to this table, I think so of the 57 patients who were recruited and studied in this particular study, I think the first cycle, they had 71 cycles. The second cycle with microfluidics, around 78 cycles. So I think looked like some patients had multiple attempts. Then they looked at the fertilization rates. Statistically, if you really look at it, 69% versus 76%. But they say that the p-value is significant. Then the number of blastocysts biopsied were again, probably more in microfluidics arm. And coming to the main objective of their paper is the ploidy status, the percentage of euploid embryos. The double density, the first cycle, the same patient who only had 25% of euploidy, in subsequent cycle, with microfluidic sperm selection that was done, it almost went up to 42.9. That's close to 43%, which again was statistically significant. So coming to table 4 here, it was more of the reproductive outcomes that they looked at. So double density gradient, the first cycles were only 19 FET cycles. And if you really look at it, only 2 patients had clinically viable pregnancy, but these 2 subsequently had pregnancy loss. They did not have a live birth in this group. I think that is what made the author think that probably there could be an issue with the sperm. And in the second cycle, the only change that they did was microfluidic sperm sorting, where 48 cycles were done in terms of frozen embryo transfer cycles. And the implantation was absolutely, not comparable at all with his first cycle. 65.5% of implantation rates, a clinical pregnancy rate of close to 65%, and a live birth rate of 62.5%, and a very, very minimal miscarriage of 3.2%. So this study inferred saying that microfluidic sperm selection seems to be offering better sperm parameters. At least the motility at the end when you're prepared is really high, the total motile concentration. A higher proportion of good DNA integrity is obtained, and it's shown to improve embryo development and the embryo euploidy rates, and thereby has offered the best reproductive outcomes. But however, I think these are few areas which I thought could be critiqued in this paper. Why was there a very high incidence of aneuploidy? And second, I think, they put back euploid embryos even in the first cycle. And of the 19 people, only 2 people having clinically viable pregnancy, and both of them miscarrying, was a little bizarre and not properly justified in the discussion bit. And if you really look at the age groups that they have taken, women 29 to 39, men from 31 to 56. So they had quite a few people who were in the advanced group age. Men 40 and above, we usually consider to be advanced paternal age, and women 37 and above as advanced maternal age. So they have taken women and men of advanced ages, and we really don't know if that is one of the reasons, but there wasn't proper justification. And second, in the methodology to test the sperm DNA fragmentation, they've used tunnel and comet. We all know again that a comet assay helps us differentiate between a single stranded and a double stranded DNA fragmentation. But what was the reason of using two methods? Is there a point for good guideline practice for all of us in clinical practice to implement? That wasn't really dealt well. It kind of felt unnecessary to me that two methods were all taken. Because at the end, it was more of the sperm DNA fragmentation that they really concentrated on. And I think with 57 patients, I think the sample size was pretty less retrospective data again. So this probably were a few of the reasons which I would critique the paper for, but take-home message, microfluidics is a new method. There are still meta-analysis and RCTs. Few of them are there, but not too many of them. But to my knowledge, I don't think there's a meta-analysis done on the efficacy of microfluidics in optimizing reproductive outcomes. So it's a fairly new method, and I'm sure we would need a lot of similar papers which try and help us understand if microfluidics can optimize reproductive outcomes. With that, I end that. Thank you so much, ACE, for this lovely opportunity to present this paper.
Thank you, Dr. Krishna, for a wonderful critique and a summary of the paper, raising all the concerns that are there, because as I started, it's a very simplistic paper. When you at first glance, it looks like, oh, change the sperm preparation method and you get better ploidy, but there are relevant questions. As per the format now, we are going to open out the discussion first between our two moderators with Dr. Krishna. So Dr. Prabhakar Singh. Thanks, Dr. Prabhakar. I know you have been traveling and rushed into it, so I really appreciate it. And Dr. Harita. For those who came in late, Dr. Prabhakar, most of us know him. He is an MD chest physician and a clinical embryologist in the last 15 years, so he has a unique perspective. And Dr. Harita is a PhD from the University College of London and primarily has spent a lot of time working with PGT. So we can discuss the paper, and after that, it's open to the audience to throw in questions and discuss, debate this paper. So over to you, both of you, the three of you rather.
I can start off just with the simplest, I think, point probably is that when you said, why did they undergo PGT in the first place? I think the age group explains it, that, there may be some who are on the higher side, even in the paternal and the maternal partners. So probably that's one reason that they could have undergone PGTA in the first place, but of course not mentioned really clearly. And just the second point is that this entire paper, I believe that with MFSS, I think is based on just motility, in the sense of all the parameters, you are looking at motility primarily. So maybe that could have, just influenced some of the results probably. Because you're only looking at sort of one parameter for it. And why did they undergo PGT? And because this is probably based in the US, I don't think they, like us, they require medically indicated conditions. And, it's the regulations are different. So probably that's why all of these are included in the first place. So, I mean, that was just an initial thought, but we can continue.
Dr. Prabhakar, comments from your end?
Yeah, thank you so much for having me. And Krishna, well done. I think it was very well summarized. It is a short paper. It's not much. I think this could have been a deeper dive paper looking at a lot of parameters and lot of age-related things, and that you just. What I wanted to ask was, if you were to do this study, what would you do? What would you change?
All right. So,
how could this study have been performed or reported?
see, well, if the thought that would sperm DNA fragmentation influence embryo ploidy is probably the question, the important question to ask, because we see so much of DNA fragmentation, and we really don't know what to how to manage it at a clinical site. So I probably would have taken the control group and tried different modalities. And just not the microfluidics, but then I would have had a better picture if it's more to do with the sperm DNA fragmentation. I would have considered only younger women and younger men, that is less than 40 years, because I would want the age bias to be removed from this. Though it was retrospective data, in subsequent this, I would only consider, because there was an opportunity to do that. So I would have preferred taken younger men and women, and then I would have looked at it. And if I really look deeper into the materials and methods, and I'm more concerned with their first cycle. Euploid embryo putting back and of 19 cycles, 2 cycles working out is a matter of concern. And second, if I read in between the lines, they seem to have put back more than one euploid embryo in the first cycle, and things didn't work out. And in second cycle, they come back and they put back only one single euploid embryo. That, for me, in the design sounded not right. And be it US or UK or India, you've done PGTA and you have a euploid embryo, putting back a second embryo sounds a little not so right. So for me, I think the design could have been further fine-tuned. It was a little confusing to understand what the author really wanted to do in this paper. The hypothesis wasn't very complicated. Can a technique of sperm prep change or improve the ploidy stages? But the approach was quite complicated to get to that point.
I think the only best part about it is that they've taken the same patient in the second cycle. So I think that kind of acts as like a control. It's like an auto control group. So you don't have to do, ideally you would have to do a split cohort, like half embryo, half oocytes you do. That's what ideally should have been done. That half oocytes you do injections with double density, and half you do that, and then maybe see. That would have been a better kind of, you match the results better, because second cycle, I don't know. They say they have not changed much, but then it does leave a lot to question that, what happened in the first cycle.
It sounds so magical that,
it does.
Microfluidics, and, the live birth went to 62%, 0% to 62% live birth just with microfluidics. Now that's something that, we got to be very careful. It shouldn't sound that, this is a new method and from tomorrow, let's just go shoot every patient with microfluidics. No, I probably don't agree with that statement. And I might, be a little more careful before I make this a routine clinical practice to all my patients.
I think the David Miller paper was much better. Yeah, carry on. Go ahead, Gaurav.
Prabhakar, can I make a comment?
Yeah, sure.
I don't buy this result. I don't buy this result at all. This this is the worst control biology with an impact factor of 0.5. Maybe the name of the authors worked, and maybe subscription help, because this that they have posed that whether sperm DNA fragmentation can be correlated to embryo ploidy. Exactly, the control group is 39-year-old women. The average age is 36 plus minus 5, not sperm DNA fragmentation. A density gradient, the sperm DNA fragmentation was 18%. So, hey, where's the problem then?
Gaurav, we're not able to hear you properly.
Which means that eight sperm DNA. So then,
yeah, your voice is breaking a lot.
Oh, voice is break. Now is it okay?
Yeah, better.
Right. So as far as the control group is concerned, they have already shown that the sperm DNA fragmentation post-density gradient is at a very low level, which is only 18%. So how does 18%, let me put it in perspective for everyone, which means that randomly when 10 sperms are chosen, 8 sperms have normal DNA. So when 80% of the sperms which are being injected are normal, how can it result into such high aneuploidy? So definitely there is something else, some other factor, maybe it's the egg quality or the maternal age, which is leading to the high aneuploidy rate, and not a 18% sperm DNA fragmentation. And then how does it help when 18% is further reduced to, say, 0%? How can that improve the euploidy rate to 42%? That is something which is beyond me.
That was a valid point, Gaurav. Yeah, that was not justified at all. And
so Krishna, if you remember, if a group would have been chosen where, say, post density gradient, the DNA fragmentation index was, say, 70% or more than 50% or 80% or 100%, and then with microfluidic they would have shown that it has been decreased to less than 10%, then you might even make sense that, okay, probably this is one huge factor which has led to this improvement. And your point very specifically, that when they got so many euploid blastocysts in the first cycle, why did none of them implant?
So probably there was a uterine or a hormonal immunological thing. And just changing a sperm the second cycle, magically changing to that numbers was sounding a little funny.
Yeah, and that too from 18% to 2%.
Yeah.
So both are, in my view, both are clinically irrelevant, because 18% is also below the normal threshold.
Yep.
Yeah.
Yeah.
Lovely.
I think if the patient selection criteria would have been very specific, that patients who have, say, advanced paternal age, for example, number one, advanced maternal age, a combination of these two maybe, and with a very high DNA fragmentation, and then you try something to kind of, mitigate the age factor and the sperm DNA factor, and then try and see what happens to the euploidy status or the implantation rate. Maybe that would have
helped in the design. Yes. So
yeah, I think 57 patients, we don't even know how many patients were 31 years old, how many patients were 37 years old. The males, we don't know how many were 56 and how many were 41. I mean, 57 patients means you could have like 2 patients in each age year.
Yeah.
I mean,
and Prabhakar, this was over a 4-year period.
4-year period.
So, which means in 1 year, only 10 patients.
Yeah.
Very interesting. Very interesting.
So
And are they reporting clinical pregnancy rate per cycle, or it's like a cumulative pregnancy rate? Like, I mean, I don't know how they reported it. Is it
per cycle?
It's per transfer. Per transfer. Okay, so that is slightly better, but still 6% euploidy rate going up to 42%. I mean, it is like putting in a magic pill. I mean, I don't know. I don't.
And I think again in the methodology, that whole single standard DNA, double standard DNA. Why did the author really bring in that concept? And at the end, in the discussion, now what? Why did you even want to test?
They don't elaborate on it at all after that.
All. To everybody's this, I'm being honest, I had my own little confusion and doubts when I read this concept. So I called up one of my colleagues who was doing a lot of work on this, and I said, tell me what is this single standard, double standard business, and why should you really do? Then she put across saying that wherever there is a higher instance of double standard DNA fragmentation, it's more to do at a testicular level itself. It's more molecular, and lifestyle management or antioxidants might not help them. Whereas a single standard is more lifestyle induced, ROS induced. Okay. So she says that kind of clinically might help, and a double standard DNA damage might bring about a higher pregnancy loss. Then I came back and I'm like, okay, probably that was in the mind of the author, because the first cycle, those 2 clinical pregnancies both miscarried. So did he want to really correlate this with the double standard breakages? If that was higher, did he want to convey to all of us that, start looking at a double standard DNA? And if it's double standard DNA breakage in a higher percentage, the incidence of miscarriage is going to be higher. And I don't know if there's an intervention.
Yes. But you see, the double standard rate is 3% after density gradient. Yes. So 3% is minuscule, right? Minuscule. It's clinically irrelevant. So then that cannot become a justification for the 2 miscarriages, right? Absolutely.
So,
I mean, we could have done a better study easily.
Point is, we didn't.
No, we need to make now we should all sit down together and we should write what should be the ideal study design to find an association between sperm DNA fragmentation and embryo ploidy. This should be our task.
Yes. So I don't know, Rajvi, if I'm allowed to share the screen. I dropped just for everybody's academic interest. I'll just share this poster that we just presented at ESHRE. So we did this is again retrospective data. So, younger women where PGT was done for the reason of RIF. And we wanted to look at the ploidy in different group of patients. So just give me a second. I'll just share it and let's quickly have a look at it. Yeah, while I'm trying to share that across, I don't know if there are any questions or inputs from the audience that we could take. Hoping the screen is visible.
Yeah.
For everyone.
Yeah.
Right. So, so in men with raised sperm DNA fragmentation, that was the criteria. Then we looked at teaser, double density, max, and microfluidics, and we had almost 84 patients in teaser group, 148 double density, 105 max patients, and 135 microfluidic patients. And then I'll take you directly to the results where we, compared the euploidy rates. Honestly, it didn't make a huge difference. Though microfluidics arm kind of gave a 61% euploidy rates. TISA was the least at 48%. But still, 48% of euploidy rates isn't low if you ask me. I think that's kind of acceptable. Though this paper said, microfluidics seems to be a better way of handling it. We didn't have an inference saying, what's more important is we've always kind of carried this notion that testicular sperm will increase embryo aneuploidy, they are immature. Should we really be using testicular sperms? The answer is yes. There's more and more data coming, which is kind of in favor, or at least is supporting that testicular sperm doesn't bring down your blastocyst formations or your fertilization rates. Your implantations or ploidy status are kind of similar to your ejaculated sperm because our culture conditions have improved. Our laboratory know-how of how to handle testicular sperm, process them, sperm selection at a higher magnification, and of course, the experience of the embryologist over the years. I think we're getting better from what we were probably 2 decades. I think 2 decades back, probably even I would have said that testicular sperm, okay, you've had a 30% FERT or you didn't get a blastocyst, we would have said severe male factor and probably thought of donor sperm. But things are changing, times are changing, technology is kind of really advanced. So I think don't really look down to testicular sperm. Please sit down with your clinician or at your end, if you really want to get in more skill, practice, improve on your sperm selection of testicular sperms, I think you could do that. This is data for almost 7-8 years that we pulled out at Oasis, and it looked encouraging. So I thought, it would kind of be interesting to everyone. I thought I'll show this here.
Interesting, Krishna. But the point is that if one has a choice, one would not really want to jump to testicular sperms. And if we can manage with ejaculated sperm using any of the techniques available, yes, surely that would be a preference, and testicular would
patient friendly. Yeah,
exactly.
Patient friendly.
If microfluidics is giving you, because it's a fairly new method, and if it seems to be giving a decent output, which is not alarming, and looking at the SOP where you just have to put 850 microliters of the sample into a chip and wait for 30 minutes to 45 minutes, and you're getting a higher proportion of total motile concentration, and if it is giving you good euploidy, I might not want to put the patient through a surgery.
True.
Yeah. No, but what your data is showing that even a simple density, double density gradient is leading to 54%. And I'm sure that these results are not statistically different. So if they are statistically insignificant, then there is no difference. For me, 61 and 54 are the same.
Yeah. So,
they are equivalent. I will call them equivalent. I will not call them different.
Absolutely. And the thought that, sometimes, we also out of desperate measures when a cycle fails, there's so much of pressure on all of us as embryologists. What do you want to do in the next cycle? Because we want results. And then, we simply want to pick up technology from baskets at time. I'm not against the technology that's changing, but I think we really need to be looking at evidence. If
what do you want to add? Say we will get you that.
So we got to play safe. We got to balance our approaches. It's also not on the other side. Condemning a technology is also not right. But at the same time, just getting hyper and shooting it to everyone also should be curtailed.
Just one quick reaction to that. Did you see the euploidy status when you did not do any of these?
Euploidy we would have done the double density, right? The method.
Yeah. So that is your standard.
Yeah, that was our control group, which was 54%, which was fine.
Yeah.
Do you do swim up after double density?
Yes, we leave it in the incubator and then we pick up and do it. So.
And what were your pregnancy rates?
Well, I think they're trying to look at it because we didn't again divide this in and look further down there. I think I'll get back on that. But our PGT program per se, we again looked at RIF patients with 2 blastocysts unscreened versus 1 euploid screened younger woman RIF history. And we were taken back, close to 8 years of PGT at Oasis. 55% take-home baby rate with PGT group, and 48 or 49% of live birth rate where no PGTA, 2 blastocysts were put back. So, we are also now, I'm not saying I don't want to do PGTA for RIF patients, but again, it is not an active intervention, which is going to be a game changer. But somebody wants to look at a cell gamete conception, they've got 10 blastocysts. Instead of trying 4 cycles, I would probably want to do PGTA. So you got to tweak your SOPs a little bit, discuss it with your clinicians, and then probably offer it to your patients.
Because then the question I'm getting to, are we looking at the right thing by looking at only the ploidy status now? We are coming to a situation that is this the final assessment? Because with all these things coming up now, you wonder whether, it is really telling us something, or the embryo is much smarter than what we think. And, an aneuploid embryo.
There's still a lot we don't know.
Absolutely.
And for everything, we try to give an answer with ploidy. That is the problem now. It is our obsession with ploidy for this generation who's trying to answer every question with the ploidy answer.
Absolutely. I think, PGT has kind of become a little fashion statement. They feel, probably they're not embryologists dejected if they do not know how to do an embryo biopsy. To all the juniors out there, if anybody's really concerned that they have still not learned embryo biopsy, relax. If you've learned QCs and you're doing good documentation, I think, you're really doing good as an embryologist. Technologies will change. Today it's PGTA. Tomorrow, I'm sure we're talking about gene editing in some time. So, we all will slowly learn it, but how far it's going to be helpful. I think you've got to do your own homeworks. SOP, what works for you? You got to retrospectively look back at your data. Just being in a race and looking at your beta HCGs and say, okay, I've done 20 cases, 16 were pregnant, and then you want to not really deep dive. I don't really like that kind of approach. I think, patients might not be with us. We need to put in efforts to see whether there was miscarriages, live births, congenital anomalies. As fertility centers, we got to keep a track of these things. If not for anybody, now I think the new law is wanting us to report to live birth. But you want to personally know that what you started ended well, and if there's something that's not going well, it's always good to go back, and there's a way of handling it well.
Any questions? There were some from the audience. Okay, I think you've already answered this. How useful is microfluidics in RIF couples? So, yeah, you've already answered that. Yeah. So anybody wishes to add something?
I just want to ask an embryologist perspective on this one topic that, I've recently come across many papers to review, and to say that what is the impact of paternal age, like advanced paternal age, on embryonic aneuploidy? What do you think of it? No, I mean, I know that it shouldn't be an indication for PGTA, but I just like to ask your...
There is this David Miller paper which talks about that, and they have, that's a huge study, 2,500 patients, which talked about comparing PIXI with ICSI, basically. And one of the conclusions of that study was that paternal age does matter, that as the age of the father or the parent paternal side increases, there is there is a problem with the sperm DNA fragmentation. Along with an advanced maternal age, which is 37, it is not able to correct that. So I think that is something. So there is a little bit of data. We're still, I think, figuring it out what exactly happens and why it happens. But I think the focus is now shifting to the age of the paternal side rather than exclusively the DNA fragmentation. I think so.
Just to add to Prabhakar's this, I think if you're keeping the female age constant less than 37, if you're only looking at the paternal age, so 40 or 45, there's still debate, but looks like people are wanting to pick 40 as the advanced paternal age now. So again, looking at the meta-analysis published so far and my own experience, the embryo development or blastocyst conversions or the aneuploidy do not seem to be increasing. The main concern is because the DNA is getting fragmented, if everything goes well and there's a childbirth, these people are prone for neurobehavioral disorders. The incidence is going up of schizophrenia, cerebral palsy, and other neurobehavioral disorders are going to go up. I think that autism is again on a rise in these children born to advanced age fathers. So, nowadays it's become a norm of a lot of reproductive tourism, a lot of African patients landing in India. They're all 53s, 56. Sometimes I've seen patients 60 coming and wanting to get treatments done. I think, these are the group of patients where, some amount of, care, and I don't know if we counsel, they're going to say no, they're going to go to another center and get it done. But what's the literature supporting? I think you're going to get blastocysts. They probably are going to implant. But I think the health and well-being of these children is going to be at a risk.
So I agree. When it's over 40, then you should be considering an extra measures. But so, routinely, definitely, it cannot be offered, is what I'd suggest.
It can be an indication, probably to optimize sperm selection.
Yeah.
PGTA, again, because, RIF, RPL, where are the two indications where we could have used. I think data is coming back questioning its efficacy. So now, let's say that I have a 41-year-old man, will I just say, go do a PGTA? The answer is no.
I think what it does is that, forget about PGTA, what limited study that we did, which we presented at ESAR, you do get more blastocysts if you're using PIXI or microfluidic. So that gives patients maybe, 1 or 2 cycles extra in case, even if you're doing like a random non-PGT transfers, you do get definitely more blastocysts, and that kind of increases the chances of the patient eventually getting pregnant. It's a Russian roulette that you're going to play, but definitely it increases your blastocyst development rates. So that is, if you're not doing PGT, maybe you can use this just to improve your, especially in very, those advanced maternal age patients where maybe you don't have the skill, maybe the patient is not ready to pay for the PGTA and all those things. Maybe this just simple intervention might still be useful and add on.
So I think to add, and probably closing remarks from my end is, there's so much that happens with the female side. The clinician is putting in so much of thought. There are probably 15 different stimulation protocols that have come up of late. I've stopped tracking them. I only knew short, long, but no longer they are the ones that are commonly used these days. Laparoscopy, so much. But when it comes to the man, we all just want the ejaculate on the day of ICSI, and we just want to pick the motile cell and whatever we think is morphologically normal. We want to shoot it into the oocyte. Let's take a step back. I think sperm selection is something that let's be a bit more careful. Let's elaborate on that. Stretch our spine and back a little more. Now, there isn't a recommendation as to which is the best sperm selection method as on today. None of the professional bodies recommend a specific sperm selection method. But I think you need to look at your own patient clientele, what your clinicians want, what the sperm parameters are like, and then try and implement what you think would give you the best. But sperm selection needs to be taken care of, be elaborated, and a lot of importance and focus is needed. That's the need of the hour. It's a different debate, should we do VC for everyone? It's going to take another decade probably to slowly go back and minimize ICSI. I won't say we will do zero ICSIs, but probably cut down on the number of ICSIs we're doing. But until then, I think let's be a bit more careful with the sperm selection.
Okay, there are two queries of the available sperm selection add-ons. Which one is the most beneficial? Max, microfluidics, Pixie, IMSI. Should DG
So we can do a poll on this, I think.
Yeah. I don't see, the point is that we are trying to find one answer for everything. The fact is that there are different conditions and some may work in certain specific conditions. Like we discussed the paper, I mean, there are certain conditions where it would work, where it may not work. So that's a problem. We think that if we replace it, it's going to improve the pregnancy rates. It's not a magic bullet. So I guess it doesn't in their different conditions. IMSI, Pixie, I mean, each has its role in different ways, I would say.
Yeah, I have a publication on this where we did we compared clinical outcomes between PXE and normal density gradient in an unselected population of infertile patients who are undergoing IVF with unexplained infertility and normal sperm parameters, and there was no difference. So like Krishna said, there's only very specific groups where some things may work, and in the open patient population, they may not have any effect.
And also when we say normal sperm, it's so vague. Basically, we are barely looking at the sperm. I mean, what we see is normal. We have no clue of how the zona selects. And we are trying to imitate a selection methodology, which is only going to select motile sperms. And out of the 60% motile, we don't know how those few hundred are actually and how that one is selected. So I think a lot more needs to be done. And in a way, I'm happy new technologies come in, some stay, some fail. But at least it's giving people a thought, because the question that always comes up when new technologies come in, that they add on cost. And like Krishna said, in the female, I mean, you'll do a hysteroscopy, you'll do laparoscopy, you'll do a monitoring, you'll do so many things. And in male, we do a semen analysis where we are only looking at number of morphologically normal. And that to me is also quite a farce with 4%. We are really nowhere. So we are really not even bothering to look at it. Until we do that, I don't think we're going to progress further. So yeah, we need to identify which of these technologies work in which conditions. So I think that's a big task. And maybe, and what I really like was the concept that Prabhakar's team put up in ISAR, where they used two technologies together. Why one? And then they showed that actually using only one was not as good as using two together. And possibly both are, I think you had used Pixie and microfluidics.
Yeah.
And they possibly work on two different mechanisms. Pixie may be more to do with the cumulus selection, and then you have the microfluidics with the DNA integrity. So possibly both together get the best.
So what did they do, Prabhakar? What did you do?
We compared, so we had like 4 groups. One was only microfluidics, one was only Pixie. And in the 4th group, we did microfluidics, and then on the same sample, we did Pixie. And then we were just looking at embryo development. We were not looking at pregnancy rates or anything. We were just looking at whether we are able to get better embryos first. I mean, that is the first criteria. And so if you compare microfluidics with Pixie group, the embryo development rate was very similar, the blastocyst development rate. But if you add these two, there's a jump in the number of blastocysts that you get. And this, we did a split cohort study, like the same patient, half you do Pixie and half you ICSI, or half you do this. So it was like the same cohort of patients with say more than 20 eggs. We divided them in these 4 groups and then tried to see what was there. So it was a very small study, just 30 patients we had. But it did show that if you combine these two, the cost increases, but your blastocyst rates definitely improve a lot.
So, I mean, would the pregnancy rates also would have improved if you have more blastocysts? I presume so.
Exactly. So if you're not even doing PGTA and the patient has chances. I mean, they have more embryos at disposal to transfer.
Correct.
Eventually, your cumulative pregnancy rate should increase. So, I mean, that is something that.
So even if a small percentage, it's worth it considering that even what would be the additional cost of Pixie plus microfluidics, few thousands, and compare that to a PGTA, it's nothing.
It's nothing, yeah.
Compared to that.
Failure of a patient,
absolutely.
If she has to undergo another stimulation.
Correct.
It costs a lot of money to them. So
absolutely.
Yeah. And technically also it's very easy to do. I mean, Pixie is as good as doing ICSI, and microfluidic is like, as Krishna said, it's like very simple process. Yeah. So maybe adding this. So as somebody asked, which is your favorite? So I would say Pixie is my favorite because I think that gives like a better this thing. I don't know. I mean, if you're using only one technology, but the problem is, I think the Achilles heel is the oats patient where we are not doing anything. We don't have anything to do with that. All these patients have like, lot of sperms to work with, and we are using all these technologies. But what about those patients who are severe oligo, severe steno? I mean, we have nothing to add to that. That is something that is going to be, I think that's the real challenge. We are not looking at that. That's a blind.
Have done some, or I wouldn't say work, but what we do with the severe oats, that's in between 2 and 5 million. Anything less than 2 million, I think TISA is probably an option.
TISA is an option, yeah.
2 to 5 million and at least a 10% motile, not even progressive, a 10% of motile fraction. If it's there, we pull up the samples, we thaw, we concentrate, we load it into the microfluidics chip, and we've seen there is recovery. And especially if these people have had a first cancel cycle elsewhere, they've come, and I've seen I've got at least better blastocyst conversions. And we did submit this to ESHRE, which didn't get accepted. And we saw that the clinical pregnancy rates were better in these people. It was retrospective, small group of patients. They had different.
You basically take, like, say, 2-3 samples, yes, make it 850 microliter.
On the day of egg collection, we take a fresh sample, we thaw these 2-3 vials, pull up everything, pellet it down, and load it into the microfluidic chip. And it will be less, but at least you get enough 20 sperms to do ICSI.
Yeah.
It works. That whole thing, the embryologists really put in efforts to pick the best sperm. There's something that's kind of the chip done and helped me. Amongst that, I picked so-called motile or a morphologically normal one, and you get decent blastocyst conversions there. So anything less than 5 million, max doesn't work, Pixie doesn't work. So I think microfluidics kind of has given us a decent outcome there. So for these patients, my choice is microfluidics.
And sometimes I feel that when the selection is so stringent, possibly we are doing something better. Yeah. Something where we are selecting because we don't know how we are selecting. But when the outcome is, instead of being happy with a very high motile sperm count for an IVF or ICSI, I would possibly be happier with a lesser concentration. Possibly there's some selective mechanism. And maybe that is helping in the outcomes that you're referring to, all those small studies or, observations. But I guess that's where it all starts because. So it has been a good discussion. Thank you, everybody.
Thank you.
Thanks, Krishna, for a good review.
Thank you, Krishna.
Thank you, everyone.
Thank you. Thanks, Harita, for your perspective. And thanks, Prabhakar. Thanks
so
for rushing in and coming in and our lineup.
Just got lucky. Thank you so much.
Thanks for that platform. It's always academically intriguing to learn new concepts on the ACE platform. So thank you.
Even if you learn one new thing, it makes your day.
I guess it started us thinking, and maybe it's time that we get together and start, because we do criticize or critique the others, but it's time we start publishing. I think that's very important. Then, and we also face the criticism, and then possibly that will make us better.
Yeah.
So thank you, everybody.
Thank you so much.
Thanks to ACE.
Thank you.
See you all soon. Bye-bye. Any questions? I think they're just the thank yous coming in. Yeah. Okay. Bye-bye.
Bye.
Anyway, it's on YouTube. So in case anybody's missed it and you want any of your colleagues to go there, we'll share the link with you all.
Thank you so much.
Okay. Bye.
Thank you.
Bye-bye.